So, good afternoon, everyone. Thank you, organizers, for this opportunity. I'm going to speak on primary ACL repair. Is there ever going to be a time where it's going to overhaul ACL reconstruction, which is the current gold standard? So, if you're doing a scope and you're viewing on the left knee from the anterolateral portal, you've gone in for the surgery for a patient with anterior instability, and this is what you find, that the ACL has torn off completely from the femoral end. At this point, as an arthroscopy surgeon, there are multiple options, treatment options that can come to your mind. What is more appropriate is a matter of debate. So you can do something called as a remnant preserving anatomic ACL reconstruction. That means you can put in a graft, and if it has to be put in the anatomic place, then you are going to destroy a few of the native fibers as well. So it could probably as well be called remnant destroying anatomic ACL reconstruction. Or you can just let the ACL be and you can augment it with a graft or a tape. But then if you're letting the original remnant be in its anatomic place, then whatever else you're going to place is going to be non-anatomic, and it's not going to be attached at the original insertion sites. The philosophically right thing to do is to just put the ACL back from where it's torn from, and that would be what we'd call an anatomic ACL repair. So what is needed for an ACL repair when you're seeing such a case and you're in surgery? One, you need evidence inside your brains. So if you know and you're convinced yourself that an ACL repair can have outcomes equal to an ACL reconstruction, then you would probably channel yourself towards doing a repair in the first place. So there is sufficient evidence for us to know in two ways that an ACL repair can perform fairly well. One, there is a kinematic analysis on cadaver studies that's been recently published, and the graph on the other side that you can see, the blue graph shows the amount of anterior instability, the tibia moving ahead of the femur, which is less than 5 mm throughout the flexion range. Now, if you have an ACL tear, then you can see that the displacement moves. That's the red curve. That's more than 10 mm when you're doing an anterior Lockman. And then if you see the repair and the reconstruction graphs, and this is by Jorge Chahala, who's really published a volume of literature on ACL reconstruction as well, you see that repair and reconstruction has hardly any difference, and both are able to restore the the stability. Also, there have been randomized controlled trials, at least 3 that I know of, and then now a systematic review and a meta-analysis of these prospective and retrospective studies, which eventually concludes that at 2 years, ACL repair is the same as ACL reconstruction, if not better. So it's the same at 2 years. It's safe. So once you're convinced that yes, there is evidence that you can repair this kind of an ACL torn of the femur, what else do you need? You need inventory, because you've gone mentally prepared as an arthroscopy surgeon just to do ACL reconstruction. So what else will you need when you want to do the repair? You'll need stitching material, which is you'll likely have because you want to stitch meniscus also sometimes. You'll need stitching devices, which you'll also have in OT because you would want to stitch a meniscus up if at all it's torn. Third, you will have augmentation material like suture tape. What you may or may not have are fixation devices. Generally for routine knee arthroscopy, primary ACL reconstruction, nobody keeps suture anchors in place. And almost all of the literature published talks of suture anchors being used to repair the ACL to the femoral footprint. There was one paper published in a lesser journal by Dr. Nishit Shah almost 9 years back, where he described 4 cases in a similar way to which we have now submitted and it's been accepted for publication, trying to repair the ACL in a cheaper way with inventory that we always have for an ACL reconstruction. So this is the same case. It's the left knee and the working portals, the anteromedial portal. Uh, we're using mini suture tape or basically high molecular weight polyethylene sutures. And this is the first pass mini by Smith & Nephew, which is generally used to repair the posterior meniscal root back. So you take one suture and take multiple bites such that you have a good hold on the remnant fibers. Similarly, then you can switch portals and use the instrument from the earlier viewing portal, which is the anterolateral portal, and take in stitches alternately so that you're not destroying much and trying to create sort of like a cylindrical bundle with a good hold so that you can negotiate or make the stump travel to where you want it to. Then of course it's torn off from the femur, so you visualize the femoral footprint, protect the fibers, and instead of putting in a suture anchor, you can actually drill a regular inside out tunnel which exits the lateral femoral cortex. And if you're fixing the ACL with suture anchors, people always suggest trying to microfracture the non-articular part of the notch to get in some bleeding, but because here you're drilling the entire condyle, there's bound to be some bleeding into the joint, and you don't need any additional microfracturing. All these sutures can then just be shuttled out and then tied over a suspensory fixation on the lateral femoral cortex. In this case, we just used a simple suture disc, which is always available. So we've operated 4 cases with a 6, 12, and 18-month follow-up. And I don't have the MRIs, but obviously it gets published and then you can see those, and there is healing and functional outcome at 18 months. So the indications of a femoral repair are adults, femoral side avulsion, acute tears, and good tissue quality. What about tibial sided avulsions? So other than a bone, if you have soft tissue can also be repaired, and we've reported that again in arthroscopy techniques in a similar way like the femoral sided avulsions. The only one enigma is mid-substance tear, and this is the last slide. So the mid-substance tear is something that we've always offered an ACL reconstruction, but there are scaffolds now in America at least which can offer an option for an ACL repair. We hope that such scaffolds come to us as well. So ACL reconstruction is the gold standard, but there is a role of an ACL repair. As of now, acute femoral sided avulsions in adults with great tissue quality must be offered an ACL repair. Thank you.